This piece is in two parts. This is part one.
Top Bed Talk.
So welcome to what I hope will be a really interesting, exciting discussion about enabling enhanced recovery. We've got a panel from all over the world. It's going to be ably chaired by Jugdeep Dhesi, who is the Deputy Director of the Centre for Perioperative Care at the Royal College of Anaesthetists in the United Kingdom, and also leads the Perioperative Medicine for Older People Service at St Guy's and St Thomas's in London. So I'm going to hand over to Jugdeep, who's going to introduce our speakers and the topic for today.
Very much, Denny. So I'd like to start by handing over to the lead investigator for the hip attack study.
So hi, I'm PJ Devereaux. I'm a cardiologist and clinical epidemiologist and perioperative care physician at McMaster University. The hip attack trial was a trial of just under 3,000 patients, and what we're looking at is to see whether or not accelerated surgery compared to standard time surgery could improve outcomes. What we were aiming for in accelerated surgery was a goal of getting people in the OR within 6 hours. We don't think 6 hours is magical, but we wanted to have a timeline that was credible, which we knew from pilot work and other work we did, but would push people to do it as fast as possible. And what the trial showed is that accelerated surgery is not a panacea. It will not cure all evils of people presenting with hip fractures. However, you do see some very important impacts on outcomes. That is, we saw a reduction in urinary tract infections. We saw a reduction in people having delirium. There was a reduction in stroke, but the stroke signal is very few events, and I'd be very cautious about the interpretation of that. We saw a reduction in moderate to severe pain on days 4 to 7 after randomization. We saw much faster times to standing, mobilization, and walking, and we saw a shorter lengths of time in the hospital. The trial was undertaken because of a patient that I had managed, which was I got a call one day from an anesthesiologist I was on in the cardiac care unit saying it was a 75-year-old woman who had presented with a hip fracture, and she had an elevated troponin, and their resident had given her fluid, and she was in some heart failure. She had some ECG changes. And at the time, I really knew nothing of the data, the observational data on the timing of fractures and the outcomes. And I think, like most physicians, I inferred a lot of information I knew from managing acute coronary syndromes to this patient who I was seeing. And this anesthetist said, look, you're going to have to fix the heart before we can fix the hip. And we embarked on management, which ended up including some antiplatelet therapy. And the patient ultimately bled and died and never made it to the OR for their hip. And this certainly made me wonder whether or not, in fact, this approach that we were taking of medical optimization might be the better approach. And the one thing that is important beyond the overall trial results, we did see in the subgroup of patients, which really was the motivation for the trial, in patients who had elevated troponins at presentation, there was a very large mortality advantage in accelerated surgery. Now, I think that this requires replication, and we're trying to get funding right now for Hip Attack 2 to focus on that group. But it may be in that group that I think it may represent that you're finding a group of patients who tell you physiologically they don't tolerate the stress of the fracture, and they may benefit the most from accelerated surgery. Again, we should have a big trial to prove that, but that's our goal in terms of this. But there are overall benefits to accelerated surgery. We saw no downsides, but it's not a panacea. If you do it just on all comers, you're not going to wipe out mortality, which remains very high.
Yeah, no, great. Thank you, PJ, and great study. Do you think we really have enough evidence already to start to suggest that there are subgroups of patients that we should push through accelerated pathways to be able to achieve better outcomes for that particular group?
I think we need Hip Attack 2. I think the subgroup that has the most to benefit from a mortality point of view from big outcomes, I do think are the people who show physiologically they don't tolerate the fracture well. I think a separate question, though, is should we just do it for everyone? And as I said, there's no doubt there's advantages. So there is an economic analysis that's happening right now in Hip Attack because it is an inconvenience to create accelerated surgeries. You have to create pathways. We demonstrated in I think there was 69 centers across the world that it's doable. The economic analysis will be interesting because you save a day in the hospital. In fact, it's almost a day and a half you save in the hospital. So yes, it is inconvenient to accelerate surgery, but at the same time, ERAS is all like a big focus of ERAS is getting people out of the hospital sooner. And you do actually decrease the length of stay, which is not shocking because you mobilize people faster, people go home sooner. So, I realize that it's an inconvenience for everyone, but I guess the question I would really ask back to people is, seeing the data, if it was your mother or your father who arrived with a hip fracture, would you not prefer accelerated surgery compared to standard care? Personally, I would, even though I don't think it's a panacea, I would prefer it for my mother and father. But it's like a lot of things in systems. We have to be willing to make system change, which also means inconvenience, for those things. As I said, whether or not there's another group within it that has a big benefit, we should unequivocally do it because there's just mortality and other big things happening. That's a separate question. But I think even with the data we have, certainly we'll see what the economic analysis shows, but there could be an argument made right now of why would we not do it. There appears to be no advantage that we see in the data to delaying surgery, even in people who presented with medical instability. People who went fast, we saw no downside.
Moving over to Paul. So Paul, would you like to introduce yourself and also give a summary of your talk?
Sure. My name is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery at Duke University, and also run the nutrition and TBN service for Duke University and run our perioperative nutrition clinic, POET clinic, subclinic, I suppose, of the greater clinics you probably heard Saul Aronson talk about. And so we're, of course, as you might gather from the lecture, if you've heard it, very passionate about really trying to ensure that no patient comes to elective surgery anywhere in the world without having nutrition being evaluated as a risk factor. And so I think first off, we don't ever want a patient to have elective surgery without malnutrition assessment occurring. And then when it's found to be present, as it is, in as many of 2 out of 3 major GI surgeries relevant to many of the ERAS patients we care for, when it is commonly found, we would advocate it should be treated before elective surgery should ever occur. And so, unfortunately, we know that this is not happening throughout the world. And so we think this is an area that has real opportunity for improvement for most, if not all, centers that do this. We've done surveys of the major academic centers in the U.S. who do GI and say surgical oncology kinds of procedures, and very few of them, less than 1 in 5 centers, are actually doing this actively now. And so the vast majority of our patients are getting to surgery without being screened. And that's unfortunate because we know your risk of mortality if you're a malnourished patient who doesn't have it treated is 5 times higher, and your risk of complications of all kinds are 3 times higher. In fact, of the top 10 causes of death in the big NISQIP, the multi-million patient surgical database in the US, a low albumin, which isn't a perfect nutrition marker, but is a reasonable one in the pre-op setting, it's the number 4 cause of all-cause death within 30 days of any inpatient surgery. And of the top 10 reasons, it's the only modifiable risk factor within a few weeks of surgery on that list. The others are things we really can't change. A lot of them are chronic disease and other patient factors. So we think it's a huge opportunity, and the data supports that. And so, as the lecturer described, I had the chance to work with many of the people in this meeting at the ACER POCI 2 nutrition guidelines session and lead that group in creating guidelines based on the data and evidence that exists. And there's a fairly large evidence base for the role of nutrition management in surgery. And we came up with recommendations to try to help people screen, and we developed a novel perioperative nutrition score, the PONS score, as you may have heard mentioned in the lecture, that we've built into our electronic medical record. It's a very EMR-friendly, less than 3-minute screen that can be done on the phone, can be done in a clinic, can be done by anyone. Really, that asks basic questions about weight loss, BMI, how much patients are eating, and then what their albumin is. And if any of those things demonstrate risk of malnutrition, we advocate those patients receive nutrition therapy. And in our case, we do it with a registered dietitian who's part of our preoperative clinic. That Duke has had the insight and foresight with Saul Aronson's help to hire an RD that we have full time now. And I can tell you, Saul has let me peek at some of the data he's analyzed for the effect of just having a registered dietitian talk to the patients. We've started a large intervention trial where we're intervening on these patients. But prior to that trial starting, just the sheer presence of an RD seeing these patients at risk for malnutrition reduced length of stay on average by a day and reduced ICU length of stay, mortality index, readmission, AFib, AKI, a lot of the variables that we measure within our effects. Just the sheer fact of them seeing this dietitian, which as you can imagine would pay for itself many-fold over. So I think this is a real opportunity for all of us. And then I think just some very basic key tenets. Mike Grocott helped me think of some simple ways to express this, and we like to call it the Pokey 6. In that pre-op screening and post-op screening for nutrition have to occur. That's the first one. Protein is more important than calories, and so I really want to advocate to the entire audience that getting protein up to 1.2 grams per kilo is more important than the total amount of calories you get in for your patients. That we need to, of course, minimize MPO periods pre-op, do our carb loads, and then restart the day of surgery post-op so that patients get fed. All patients, whether they have nutrition risk or not, should get high protein oral nutrition supplements for the month after surgery. We know that oral intake after surgery is immensely poor and does not meet requirements. And then, of course, oral nutrition before enteral, before parenteral, but parenteral does have very good data. It's one of the few grade A recommendations in most nutrition guidelines. If a preoperative patient's at nutrition risk and can't get oral or enteral, they should get parenteral nutrition. And it does not associate with infection any longer. There's no relationship with TPN to infection. It's just as safe, I would say, to put saline through a line as it is to put TPN through a line. I think that's something we're not taught very often. And then the final thing is nutrition management's a team game. You need your dietitians, you need your nurses. Just like ERAS is a team sport, nutrition is too. And less than 25% of at least U.S. medical schools teach any clinical nutrition in all of medical schools. So we as physicians are not taught this inherently. It's why it doesn't receive much attention. And so we need our dietitian and our other colleagues that are better than we are at this to be able to be part of this team. I really advocate to all that this is a crucial part of what we do every day. It's something that can't be overlooked, and it can really change the outcomes for patients before and after surgery. I think one of the things we're really excited about, and we've brought some people that are really uniquely skilled in this over from the Netherlands and other places, is the use of CT scan, MRIs, and then bedside ultrasound to measure sarcopenia, which many obese people are severely sarcopenic, not all, but many. And we think much of the future of objective surgical risk and nutrition or malnutrition diagnosis lies in these much more objective measurements of muscle mass, which we see as a human's metabolic reserve for surgery, right? Surgery is like running a marathon. And if you have the reserve to do it, you'll run well. And if you don't train and prepare and carb load and hydrate and do all the things that a good runner would do, you're likely not to do well. And so we are actively pursuing protocols with our radiologists and others to use MRI, and we're looking at starting a study of multi-level spines, and we're also very interested in hip fracture as well, where multi-level spines routinely get MRIs. It's a beautiful gold standard muscle mass measurement that will validate against our handheld ultrasounds. There are muscle-specific ultrasound probes that are built to measure muscle. They're about this big, and they plug into your iPhone, and we're going to put them in our pre-op clinics with all, and in 5 minutes, you can get all the muscle data you need to tell if your obese patient or your thin patient is sarcopenic, what the quality of that muscle is, what the energy state is. We can measure glycogen very rapidly. And so we really think that is an essential part of the future of surgery, especially of the elective surgeries we participate in diagnosing and then knowing who to treat. And then you can follow these markers by ultrasound. You can see if the muscle's responding. You can see if the nutrition's being taken up. And so we think this is a huge opportunity. And I think the other piece to get to obesity is, of course, malnutrition is more than just muscle and what the patient looks like and what they're eating. We think there's specific nutrient deficiencies, especially as you begin to talk about COVID, that are very relevant to a person's outcome and require further study. And one, of course, is vitamin D. There's a beautiful 10,000 patient, almost 11,000 patient meta-analysis in the BMJ that shows that repleting vitamin D can reduce your risk of upper respiratory infection 50, 60, 70%. In people who are deficient, and 30% in all comers. And this was a really robust meta-analysis BMJ published recently. And this is COVID-like disease. This is other respiratory disease. This is post-op pneumonia disease. And so we think there's a huge opportunity. And if you guys all out there aren't taking vitamin D, take 4,000 a day. You're going to reduce your COVID. You're going to reduce your risk of getting influenza come the fall. Your patients, we believe, and this needs study, and I think we're very interested in doing this research, are going to be less likely to get sick. And then the other is the microbiome and the probiotic balance. We have a huge trial I was just talking about before that we know that in a Nature paper of 8,000 subjects, taking a lactobacillus probiotic can reduce your risk of respiratory infection somewhere between 30 and 50%. And again, this is one of the premier clinical trials done in the world in the last 10 years. It was published in Nature, and it shows you the effect of a simple probiotic you can literally get at the store or get online in changing your fundamental risk of respiratory infection. We believe we have a proposal to PCOR here in the U.S., 25,000 surgical patients with 5 centers to see if we can reduce COVID risk as we restart surgery in the U.S. And so again, if you're not taking a lactobacillus probiotic right now, I think you probably should be. The data is conflicting. And I think that is the other kinds of things in surgery we can begin to think about. These are hugely well-done trials with multiple meta-analyses, nature-level data that cost pennies to give and have almost no risk. So real opportunities, I think, for all of us.
So, Chloe, would you like to introduce yourself and give us a little summary of your talk as well?
Thank you, and thanks for having me. My name's Chloe Grimmett, and I'm a behavioural scientist based at the University of Southampton, so a non-clinician. The talk that is available to watch, I describe the two components of psychological rehabilitation as far as I see it, and the work that I've done has been exclusively in cancer patients. And that's considering the psychological status of an individual at the point of diagnosis and the impact that that has on their outcomes after surgery. And the other part talks about behaviour change and how we can support people to engage in the prehab programmes that we're proposing and potentially support longer term behaviour change after that. So in the talk, I outlined some of the evidence that we've got that baseline psychological factors, particularly things like anxiety, depression, and self-efficacy, so someone's confidence to manage the illness that they've been diagnosed with, have huge impacts in terms of their outcomes, both immediately post-operative for things like pain, but also for longer term quality of life in the year or two after surgery, for example. So obviously that leads us to think that, well, would intervening on those psychological factors as close to the point of diagnosis before treatment, might that improve patient outcomes? And then the behavioural science comes in. There's been a lot of it used in the rehab world in terms of supporting rehab, and it becomes increasingly important as we move away from the clinic-based prehab trials and services, which are highly supervised and provide patients with a lot of support and a lot of structure around their prehabilitation, and moving towards more home-based, more self-determined behaviour. And if we use the behaviour science evidence that's there to support the planning of those interventions and really support our patients well, we've got a much better chance of supporting them to engage in the prehab programmes that we're seeing increasingly are so positive for them.
And I think, what's interesting, having been on some of the EBPOM journey over the last few years, is the fact that we have been talking about some of these issues over a number of years now, about trying to change behaviours, empower patients, engage in different lifestyle modification. But we don't seem to have quite got there yet.
Yeah, similarly to Paul's reflection on nutrition being a team sport, well, behaviour change support is absolutely that as well. There is some training that can be done across all healthcare professionals that can support them to have these sort of conversations with patients. I know there's quite a bit of evidence, some studies that have looked to ask healthcare professionals what might the barriers be to promoting things like, increased physical activity and change in diet, mostly in the survivorship field, but it's still relevant. And oftentimes clinicians, time is obviously an issue, but concerns about stigmatising patients and inferring blame is quite a common referred thing, and they're concerned that that might impact on their relationship with the patients. And also, some clinicians are not necessarily convinced by the evidence of the impact of things like physical activity and outcomes. And so, education and support's definitely got a part to play in it, without a doubt. But I think it's definitely a cultural shift of putting the patient at the centre of everything, which everyone is obviously moving towards now. And the more we can involve patients in the conversations around their care and increase their understanding, the more chance we've got to help empower them to make the changes. And also to make sure that we understand the priorities for them is really important, and not to make assumptions about what those might be, and taking into consideration other life factors that these people are dealing with, and sometimes simply providing advice on what might be advisable for them doesn't take into account, all manner of barriers they might be facing at home or what have you. So, yeah, it's a complex one.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.